Hello, everyone. This is Benjamin Farrell from IASP, and I would like to welcome you all to today's webinar. Today's webinar is one of our series related to the 2022 Global Year for the Pain Knowledge into Practice and Translating it. Before I introduce our moderator, I did want to bring to your attention that there are several ways to actually participate in the webinar today. After the talks, we will have a Q&A session, and you can type in your questions in the Q&A area of your Zoom meeting control panel window. You can submit questions at any time that you would like, and we will also be recording this webinar, which will then be available on our Pain Education Resource Center, or PERC, and that's found on our IASP website. Now, I have the pleasure of introducing our moderator, Suleiman. Suleiman is a senior research scientist in the Yale School of Medicine and Graduate School, and deputy director of the Center for Restoration of Nervous System Function at the Veterans Administration Medical Center in West Haven, Connecticut. He has served on the scientific advisory boards of the Paralyzed Veterans of America Educational Foundation, and is currently serving on the board of directors of the National Disease Research Interchange. He has published more than 200 primary papers and reviews and has established national and international collaborations with academic and pharmaceutical groups. So without further ado, I turn it over to you, Suleiman.
Thank you, Ben. Thank you, everyone, for joining us today for this second webinar in our series. It is my distinct pleasure to introduce today's speaker, Professor Didier Bouhassira, who will be talking on translating findings from non-pharmacological interventions to treat pain into clinical practice. Didier is a clinician scientist in neurology and neurophysiology, and he is the director of the In-Serum Laboratory of Pathophysiology and Clinical Pharmacology of Pain in Paris. Didier is an active member of several national and international scientific societies, including, of course, the IASP, and he is a past president of the French Pain Society. Didier serves on the editorial board of several journals, including the journal Pain, which is the flagship journal for IASP. Didier has published more than 220 papers, many of which have been cited hundreds of times. These are very influential papers in the field. We are very fortunate to have him tell us today about the latest in using neuromodulation of brain circuitry for the treatment of pain. Again, I encourage the audience to post questions in the Q&A box, and we'll have time at the end to address them. Didier, the audience is yours.
Thank you. Thank you very much, Suleiman, for this kind introduction. And I'm really pleased to participate in this ISP webinar for this translational year. Yes, I'm going to speak about neuromodulation based analgesia, and I would like to show you that this is a typical example of success story for translational pain research. I would insist on the fact that this translational pain research is bidirectional. It's not only from the basic to the clinic, but also from the clinic to the basic. So I don't have any disclosure regarding this presentation. So you all know, I suppose, that a number of neuromodulation methods are used routinely in the clinic, including the TENS, the spinal cord stimulation, and other more invasive techniques such as brain stimulation or non-invasive brain stimulation. And I would like to present today I will make a small historical tour to show you how these methods were developed, coming from basic research, and I will of course will insist on the most recent ones, the non-invasive brain stimulation techniques, which have been largely developed in the last decade, I would say. So these are the most known, the most used neuromodulation methods, but there are other methods such as vagal stimulation, supraorbital stimulation, occipital stimulation, which are also used in the clinic, although probably they are less developed for some of them. So, as I said, most of these techniques, not to say all of these techniques, were directly derived from major discoveries made in the pain field. Not really recent ones, actually, but still really major and influential discoveries regarding the mechanism of pain modulation, the organization of the pain modulatory systems in the brain and the spinal cord. So I'm sure that you all know this extremely famous paper and the diagram, which was published a long time ago. And actually it was probably the beginning of this story. And I wanted to start with this very classical, very famous paper and this very famous diagram of the gate control theory, which was extremely influential in our field. And as you know, this described this is a theory, but this has been shown to be at least partly true. And we know that there are interactions between the small and large afferents in the spinal cord, and with an inhibition of the pain signals, which are transferred by the small afferents when the large afferents are activated. So, as you know, of course, this theory was directly translated into the clinic a very few years after its presentation, its publication, since direct clinical applications were seen less than 5 years after publication of the theory, in particular the spinal cord stimulations, which directly aimed at activating this gate control system. And it is interesting to see that at that time, the translation from the basic to the clinic was extremely rapid, and I'm not aware of any such success in the recent research. For drugs, for example, we cannot expect a translation with less than 10 or 15 years after description of the mechanisms in animal models. So this was quite exceptional. It was quite interesting. And as you probably know, spinal cord stimulation is largely used now over the world. For example, over 30,000 implantations in the US, and there have been major technological innovations regarding the electrodes, stimulators, etc. But it's not my point today. So just to remind you that we had a very typical example of translations from basic to clinic, very rapid translations. And of course, the techniques are also evolving, and new stimulation paradigms are developed, notably those using high frequency bursts, which are really interesting. And for example, because you can do some double-blind study with this kind of paradigm, because you do not induce paresthesia, as it is the case with the classical stimulation paradigm. And of course, so the research is still ongoing in this field. And interestingly, and we have here a first example of back translational research, because actually from this, on the basis of this clinical data, some authors reinvestigated the mechanisms of action of spinal cord stimulation in animal models of neuropathic pain. And it was shown, like in this, as summarized in this review, relatively recent review, that actually the mechanisms are probably much more complex than just the gate control in the spinal cord. And we know now that actually the mechanism of the analgesia induced by spinal cord stimulation also involves some supraspinal controls, namely the descending inhibition, and there are more information regarding the neuropharmacology underlying these analgesic effects. So just we have here a very nice example of translations from basic to clinical applications, and then back translation to the basic research to further investigate the mechanism of action. Of course, the second major discovery about the same time, the late 60s. So it was quite a long time ago, and you probably all know this very famous paper also regarding descending modulations and the descending modulation and the effects of electrical stimulation in the PAG, the periodical gray, in rats, producing very powerful analgesic effects in these animals. And this was the starting for a large, huge amount of studies trying to analyze, to investigate, to study the mechanism of action of this analgesia induced by focal electrical brain stimulation. And it was shown that, of course, you can produce this from the substance, from the PAG, but and that these effects are mediated by a connection between the PAG and the raphe magnus in the medulla, and then there are descending fibers, descending pathways to the spinal cord to inhibit the transmission of nociceptive signals in the dorsal horn of the spinal cord. And so we have a lot of information regarding this descending modulations, and we know that the system is quite complex, involving a lot of structures, not only the PAG and the RVM, the rostroventral medulla, but also many other brain structures, including some cortical areas such as the prefrontal cortex, anterior cingulate cortex, which are involved in these modulatory systems. And just to, I like this diagram, which is quite complex and quite busy, because just to show you that actually the picture of this descending modulation is now regarded as very complicated, with both descending inhibition but also descending facilitation. And as you can see here, the number of neurotransmitters and neuropeptides which are involved in these modulatory systems is huge. And obviously, these systems are very complex, but they are extremely powerful. And they have been, these works, these studies have been, again, directly translated into the clinic. And because it was relatively easy to try to, at least in principles, to try to reproduce this electrical stimulation into the brain of patients. And I must admit that some very courageous neurosurgeons did it as early as the 1970s, and they tried to reproduce the effects of focal deep brain stimulation. And the main targets were, as in animals, the periodical gray, PAG, but also the thalamus, or sometimes both targets. So actually, when you have here the number of deep brain stimulation which have been performed according to the years, and as you can see, the number of implantation, the number of treatment has increased from the 1975 to 2017 here, but mostly these techniques of deep brain stimulation were used for neuropathic pain, phantom pain, but also for complex regional pain syndromes, fell-back surgery syndromes, etc. So a large number of etiologies. But you can also see that the number of patients implanted is not that high, and because actually the clinical development of this approach was relatively modest, because as you can imagine, it is not easy to propose to a patient to have a deep brain stimulation, which is quite invasive. And of course, if you stimulate in these areas, such as the brainstem, the risks are not that low. So because of this invasiveness, these techniques did not develop much into the clinic. And a few years after, another technique, and I wanted to address this because this is directly the work that I'm going to present after is directly derived from this first study, which was done in Japan by Tsubokawa. And interestingly, in this paper published in 1991, these authors reported in the same paper, both experimental and clinical results regarding the effect of cortical motor stimulation on pain. And here you have the effect of cortical motor stimulation in cats, on the thalamic neurons in cats, showing the inhibition of the response of thalamic neurons induced by primary motor cortex stimulation, M1 stimulation in the cat. And in the same paper, these authors reported the effect of the same kind of stimulation, peridural electrical stimulation of the primary motor cortex in a small group of patients, but reporting similar analgesic effects in patients. You have here an example of direct, I would say, translational research from animals to the patients into the very same paper. So this technique of motor cortex stimulation, invasive motor cortex stimulation, although it was much less invasive than the previous deep brain stimulation, it is still regarded as an invasive approach, but it has been used in a relatively large number of studies, large number of centers, and you have here a relatively recent review showing that it has been used mostly in patients with neuropathic pain, central or peripheral neuropathic pain. But again, the total number of implanted patients throughout the world is relatively small, actually, several thousands, not that much. And again, because of the invasiveness of this technique, it is not very easy to propose to a patient to be implanted for refractory pain, even if pain is refractory. Many patients do not want to receive this kind of invasive treatment. But all these studies based on invasive techniques were very important because they were, and as I said, they were directly derived from animal studies, and these clinical data were then at the basis of the development of new approaches, which are non-invasive and which may largely develop in the next few years. So just regarding this invasive cortex motor cortex stimulation, there has been also, again, some kind of back translation because the mechanism of action were not that clear. And for example, you have here two studies from a French group from Lyon, and they showed that actually using PET imaging, that actually the effects of motor cortex stimulation were dependent on the endogenous opioid system, and of course this has also been shown in animal studies, and again the role of the PAG and the role of the different neuropeptides, and especially the endogenous opioid peptide has been again reinvestigated in more details in these animal studies. So again, a nice example of back translation from the clinic to the animal to further investigate the mechanisms. But as I said, and this will be the main topic of this presentation, actually all these works have have been the basis for the development of new techniques, new approach. And obviously, as I said, it was not that easy to use these invasive approaches in patients. So when these non-invasive brain stimulation techniques were developed, and this was not completely new actually, but their application in the pain field is more recent. And you have two main techniques that can be used in the patients: rtms, transcranial magnetic stimulation, or TDCS, transcranial direct electrical stimulation. So, of course, the main advantage of both of these techniques is that they are non-invasive, and the goal, the main objective, is to reproduce the effects of this invasive approach with using non-invasive approach in patients. So the principles, I will mostly, I will focus on the magnetic stimulation, because we have more data regarding this technique. So the principles are very simple. You apply a magnetic field through the brain, and this will produce an electrical field in the brain, and this will result in the activation of some fibers. And we know that the clinical effects are mostly related to the activation of fibers running very superficially in the cortical areas, in such a way that when you stimulate one specific focus, you can activate brain areas which are located quite remotely, because we know that these fibers, these superficial fibers, are connecting different brain areas, cortical areas together. So there are a number of technical aspects which are not going to details here regarding the orientation of the coil, frequency of stimulation, site of stimulation, of course, which are important to get the clinical effects. So regarding pain, two main cortical sites have been used, most primarily the primary motor cortex, M1, but also the dorsolateral prefrontal cortex. And why the primary motor cortex? As I said, just to try to reproduce the effects of the invasive electrical motor stimulation by non-invasive stimulation. And why the prefrontal cortex? Because we know that this area is very important for pain modulation. And we also know that this rtms of this area is also used to treat depression, and psychiatrists have a long experience of the use of this approach in their patients. So it was interesting. So it has been. These were the two most studied sites for pain. So regarding the parameters for stimulation, usually a relatively high frequency of stimulation is used, 5 Hertz, which is supposed to activate the fibers or the neurons. And usually, usually the stimulation intensity is below the motor threshold. So that means that when you stimulate the motor cortex, you do not induce any motor movement. So why the motor cortex? As I said, just to reproduce the effects of this invasive approach. So what do we know about rtms and pain? So the first reports are not completely new, about 20 years ago. And then the first report in neuropathic pain patients, then a number of studies in experimental models in healthy volunteers, but also in animal studies were performed approximately in the same time. And very recently, actually, a relatively large number of studies in chronic pain syndromes, mostly neuropathic, but not only neuropathic, has confirmed the efficacy of this approach. So just this is actually probably the first or one of the first report regarding the effects of rtms of M1, the primary motor cortex, in patients with neuropathic pain. It was a relatively small cohort of patients. This was done in France by my friend Jean-Pascal Faucheur, and they show at that time that it was possible to induce significant analgesic effect in patients with neuropathic pain but only when relatively high frequency of stimulation were used, then hertz, and by contrast, a lower frequency of stimulation was not effective, and in comparison with sham stimulation. And so this was probably one of the first report, in a control study. And interestingly, in this very first study, it was already shown that the maximum effects of rtms after only one session of stimulation was not immediate. It did not appear immediately after the stimulation, but was maximal only 2 to 3 days after the stimulation, and that the analgesic effects could last several days after the stimulation. And this was extremely interesting because this delay in the apparition of the analgesic effects and the duration, the relatively long duration of the effects after a single stimulation session, which lasted 20 minutes, okay? And you can induce relatively long lasting, several days of analgesia after only 25 minutes. And this is extremely interesting because this clearly suggested already from this very first study that these analgesic effects were probably related to some neuroplastic changes in the modulatory circuitry in the brain. So then a number of studies have been done in experimental pain in healthy volunteers. For example, we did this study about 12 years ago, and we showed that it is possible to induce analgesic effects on cold pain thresholds in healthy volunteers. And interestingly, and this was the main goal of this study, actually, it was to verify whether the effects were somatotopic after the M1 stimulation, or if it was possible to induce diffuse analgesic effects. And actually, we showed that it was after a single unilateral M1 stimulation, you could induce bilateral and diffuse actually analgesic effects. And this was extremely important and interesting because this suggested that this approach could be used also in patients with diffuse pain, such as patients with fibromyalgia. So what about the mechanisms? So the main hypotheses were from the beginning that actually the main action was again on these famous endogenous pain modulation systems, most notably the descending systems, but also there are some indications that changes in cortical excitability, because there are also a number of systems which are directly organized in the cortex, and there are changes in this cortical excitability which were also probably involved in the mechanism of action. Sorry, but in any case, the objective, those hypotheses had to explain the long-lasting effects, and which were probably related to long-lasting neuroplastic changes in the central pain systems. So it was shown that actually when you stimulate M1, because it could be surprising that stimulating a motor system, you will induce analgesic effects. And actually we know that the effects, the stimulation of M1 are not related, the analgesic effects are not related to an activation of the motor system. For example, the pyramidal system, which come from the M1 to the spinal cord, is not activated with the intensity of the stimulation that we are using in the patients. So clearly, that means that M1 is only a way to activate many other brain areas which are known to be involved in pain modulation, such as the prefrontal cortex, anterior cingulate cortex, and other areas. And this has been confirmed using functional imaging in humans, and clearly showing the activation of, for example, the PAG or the anterior cingulate cortex after stimulation of M1. So clearly, this is not an effect which is directly related to an activation of the motor system, but again, an activation of the modulatory systems. So we showed actually also trying to better understand the mechanisms underlying this analgesic effects. We tested the effects of naloxone. Our goal was to test whether the endogenous opioid systems were involved in this analgesia, in these analgesic effects. And actually, as you can see here, after administration of course, it was a double-blind control study in healthy volunteers, but we could completely block the analgesic effect after an administration of naloxone, and of course, nothing happened after administration of the placebo. So clearly suggesting that the endogenous opioid systems are involved in rtms-induced analgesia. And we'll see that this has been confirmed in more recent studies in animals. So the other main hypothesis concern cortical excitability, and it is possible to analyze different types of cortical excitability, most notably short intracortical inhibition and intracortical facilitation in humans, directly in humans, by using specific stimulation paradigms based using paired pulse. So you apply two pulses, and depending on the delay between the latency between the two pulses, you can recruit either the inhibitory system, the cortical inhibitory system, or the cortical facilitatory system. And this system involves either the GABAergic systems, or this inhibition or facilitation involves the GABAergic and the glutamatergic mechanisms. So it is relatively easy to measure these parameters in patients. So, we showed that actually, again, consistent with an action of these glutamatergic systems, that ketamine induces a significant decrease of rtms-induced analgesia after both M1 actually, but also when it is produced by prefrontal cortex stimulation. So again, confirming that glutamatergic system, probably through the NMDA receptors, are also involved in rtms-induced analgesia. And this is also compatible when we know the role of NMDA in the neuroplastic changes in the brain, that of course neuroplastic changes are involved in these analgesic effects. And the role of the changes in cortical excitability was also confirmed in patients, directly in patients. For example, in this study showing that the analgesic effects in patients with chronic neuropathic pain induced by M1 stimulation, primary motor cortex stimulation, was directly correlated to changes in intracortical inhibition. So when you stimulate at baseline, the patients had a decrease in cortical inhibitions, but after stimulation, brain stimulation, there was an increase of cortical inhibition, and this increase in cortical inhibition after stimulation was directly related to the analgesic effects. So clearly suggesting that there is a direct correlation, a relationship between that these changes have a role in the analgesic effects. So this has also been shown, for example, in this study in patients with fibromyalgia. So when you look for abnormalities in these patients, you find them, and actually we show that these patients present with both a decrease in cortical inhibition and cortical facilitation, and I will show you some other results showing that there is a direct correlation between these changes and the analgesic effects, long-term analgesic effects produced by M1 stimulation in fibromyalgia patients. And interestingly, we showed that actually there was a direct correlation between changes in both the inhibition and cortical facilitation and the intensity of fatigue. And as you know, fatigue is almost as important as pain in these patients, and it is a major symptom of fibromyalgia. So again, there was a number of back translational research, but the goal was to try to understand the mechanisms underlying these analgesic effects. And this we summarized some of them in this review, but I will insist on more recent ones in a few moments. But at that time, it was already clear that opioidergic system, norepinephrine, serotonergic systems, etc., were involved in this analgesic effects. But although it was not possible to draw a unified image hypothesis regarding these mechanisms. So in parallel, the clinical studies, as I said, there was a number of clinical studies which were conducted in different etiologies, mostly peripheral and central neuropathic pain, but also fibromyalgia. I mentioned that one moment ago, but also other etiologies, including headaches, orofacial pain, visceral pain, etc. So a large number of studies, but most of them in patients with neuropathic pain or fibromyalgia. We have now a number of meta-analyses, guidelines, reviews, etc., and which confirm the effect of M1 on neuropathic pain, but all these reviews also emphasize a number of limitations, and this was, for example, emphasized in these Cochrane reviews. There was a lack of multi-center studies in large cohort of patients and a lack of long-term studies. Most of the first studies only were performed for only a few weeks, 3 to 5 weeks, or a few days. So it was not enough to confirm the interest of this approach in chronic pain patients, which have to be treated for many months. And also there was some methodological criticism regarding the lack of true double blinding in this study, because at that time it was one of the investigators had to choose to apply the sham or the active coil, and therefore this investigator was not blinded, although usually it was not involved in the rest of the study, but still it was not a complete true double blinding study. So regarding the long-term effects, I just mentioned that before. Actually, we did one of the first studies showing in chronic pain patients that it is possible to maintain for a long period of time the analgesic effects of M1 stimulation. And this study was done in fibromyalgia, not in neuropathic pain, but in fibromyalgia. And we use a specific paradigm, a stimulation paradigm, including an induction phase consisting of daily stimulation for 5 days, and then a maintenance phase, including first weekly stimulation, then fortnightly stimulation, and at the end of this phase, use only monthly stimulation, and the total duration was 6 months, 25 weeks. And as you can see, we could show that we were able to maintain the effect, the analgesic effect. This is the active stimulation, and this is the sham stimulation, the effect on average pain intensity. And you can see that there was a significant decrease, and which was maintained up to the 25 weeks. So at that, I remind you that we use only monthly stimulation here at the end of the protocol. So this was quite encouraging regarding the long-term effect. And interestingly, we had not only an effect on pain intensity, but also on other parameters, clinical parameters, including related to quality of life, including activity, walking, sleep, etc. Fatigue also was improved. So clearly indicating that the effects of rtms stimulation was not only analgesic, but a more global effect in the patients. And we also had improvement in catastrophizing. You probably know that this is also one of the major symptoms in these patients, and this was improved in this study. And again, as I said, these patients present at baseline with changes in cortical modulation, both cortical inhibition and cortical facilitation are decreased at baseline. And interestingly, we measure these parameters over the long-term treatment, and we showed that there was an improvement restoration of inhibition, but also of facilitation at the end of the treatment. So a direct effect on electrophysiological effects that we could measure, we could objectivate in this patient. And interestingly, there was a direct correlations between the change in inhibition and the change in pain intensity, and the change in fatigue, and the change in fatigue and the change in cortical facilitation. So clearly suggesting that this has something to do with the mechanism of action, the clinical effects of M1 stimulation. So this was in fibromyalgia, and even more recently, we tried to reproduce the same study in patients with neuropathic pain, because we didn't know if it was possible to maintain the effect of rtms in patients with neuropathic pain. So we did a study very similar to the one we did in patients with fibromyalgia. This was the first actually multi-center study, a relatively large number of patients, and again, a very similar protocol for 6 months. But in that case, we largely improved the methodology by using neuronavigation and also a robotized stimulation. I will explain that in a moment. And we also use a specific double-sided coil, which for the first time allowed to a full double blinding in this study. And in addition, for the first time also, we directly compared M1 and prefrontal cortex stimulation, because we didn't know if prefrontal cortex stimulation could be effective also in patients with neuropathic pain. So I will not go into details. The primary outcome was change in pain intensity, but of course, we also assess a number of secondary outcomes, including quality of life, etc. The inclusion criteria were very classical, nothing specific here. And this is the study design. So very similar to the one I presented before for fibromyalgia: induction phase for 5 days, then maintenance phase with weekly, fortnightly, and then monthly sessions at the end. So the total number of sessions was 15 for the patients, with either sham, prefrontal cortex stimulation, or M1 stimulation. So as I said, we used innovative technologies to improve the accuracy of the stimulation and the reproducibility of the stimulation over the long-term treatment. So that means that was done by using neuronavigation, which was directly connected to a robot, allowing to change the position of the coil here if the patient who is sitting here is moving during the stimulation. So the robot is correcting the position of the coil automatically. And we use this very specific coil, a double-sided coil, which allow a true double blinding. So this is just the flow chart, about 50 patients per group. The patient characteristics were very similar in the different groups. And these are the main effects: a clear analgesic effects lasting up to 25 weeks in the motor cortex stimulation group, which was significantly higher than the effects in the placebo group, here in green, or in the prefrontal cortex stimulation group in red. So clearly a significant effect of motor cortex stimulation, but a lack of effect of prefrontal cortex stimulation as compared to placebo. So this was on mean pain intensity. So this was a decrease in mean pain intensity. And we also measure fatigue in these patients, and we also had nice effect on fatigue, again, only for the M1 stimulation, but not for the prefrontal cortex stimulation or placebo stimulation. So we also had some effect. We used the McGill Pain Questionnaire to assess sensory and affective score. So we had more effect on the sensory aspect than on the affective aspect. And we also had an overall improvement in this patient as measured by the global impression of change, which were much better improved in patients receiving M1 stimulation as compared to prefrontal or placebo stimulation. and very importantly, actually, we confirm in this study that these techniques, this treatment is extremely safe. Look at the side effects, the comparison of the side effects in the three groups: motor cortex stimulation, prefrontal cortex stimulation, and placebo. Actually, they were similar. Very few side effects, mostly a transient headache or migraine, but they were similar between the three groups. Okay, so it is a very, very safe technique. And again, so these are the clinical proofs. Now back to the mechanisms, and a number of studies have been done to try to dissect, to investigate the mechanism of action. And I will mostly insist on this one, which was published very recently, a few months ago, by the Rohini Kuhner group in Germany, and because they were the first to try to analyze the long-term effect of brain stimulation, motor cortex stimulation in a mice model of neuropathic pain, and try to analyze the mechanism of action of these long-term effects. And so they measure mechanical allodynia, cold allodynia, but also anxiety in these mice. And interestingly, they showed that actually it is possible after a single series of stimulation to induce long-lasting effect, very similar to what we've shown in patients, up to 21 days after one stimulation, after 5 stimulation days. So long-term effect, and this was on mechanical allodynia in this mice model. But they also showed some effect on anxiety, as you can measure in this specific model of place escape avoidance paradigm. I will not go into details here, but interestingly, they also, and this is the main interest of this back translational studies, they can address that we cannot do in the patients, the specific mechanism of action. And they show the role of the PAG, the periaqueductal ray, and also the changes in the dorsal horn of the spinal cord, clearly suggesting that there was some changes in descending modulation induced by this stimulation in the motor cortex. So, just to finish two slides, the future. Of course, we can expect new technological innovations, new stimulation paradigms, and new stimulation sites. And this is already ongoing. New stimulation sites, for example, the insula is tested now in the patients, but also in animal studies. And there are a new type of coils which are also used. For example, this one, which allow more diffuse and more deeper stimulation. And for example, we showed relatively recently, that using a very different paradigm based on burst, that it is possible to induce similar analgesic effects as the classical stimulation paradigms. But in that case, the stimulation session lasts only 3 minutes versus 15 minutes. And this is quite interesting for the patients. So my conclusions. Actually, we know that a large number of neuromodulation techniques are routinely used in the clinics, and this is not new, of course. And the development of these techniques were directly derived from basic research. But I insist on that, clinical data have also guided basic research directly. And so the research, this research field is a nice example of successful translational research, but again, it nicely illustrates the fact that translation should be bidirectional. Thank you very much for your attention. You're mute.
Thank you, Didier, very much for this comprehensive tour de force, as they say, of the field, and very engaging presentation. There are a few questions, obviously, that come up. I'm going to start with the questions from the audience. So one question is: have you considered applying stimulation to both the M1 and the PFC using the rtms to see if there is a potentially synergistic effect there or not? And just as a corollary to this, were you surprised that there was no effect in your studies with stimulation of the LPFC?
So I'm not aware of studies trying to combine the two stimulation sites, M1 and the LPFC, but this could be done. This could be done. This is feasible. It is more complicated to organize, but this is feasible, and in principles, why not? It could work. And and your question was I surprised by the fact that the LPFC stimulation were not effective? I would say yes and no, because we had data in healthy volunteers showing that the LPFC stimulation were effective on experimental pain in healthy volunteers, and we know that the LPFC stimulation are quite effective for depression. And we know that depression is a comorbid symptom in many chronic pain patients, including neuropathic pain patients. And but the problem is that in this study, like in most of the clinical trials, we excluded the major depression, the patients with major depression. So we just assess depressive symptoms, but we didn't include patients with major depression because it would have increased a lot the heterogeneity of the patients. So we decided to exclude these patients. But I would say that in practice, in daily practice, we do have patients who have both pain and depression, and obviously in these patients, it would be probably very interesting to combine the two sides.
Thank you, Didier. Next question is coming from Ian Gilron. So merci beaucoup for an excellent presentation, Ian writes. Are there any secondary analyses looking at interactions with non-invasive modulation interventions and different drugs that patients are taking other than in the ketamine study? Just as in depression, CBT useful?
Yeah, thank you very much, Jan, for this question. No, actually, regarding there are data in depression regarding the modulation of the effects of rtms by drugs, but regarding pain, actually, I'm not aware of this. Besides the studies that I mentioned using naloxone, ketamine, there are relatively few controlled studies, I would say, trying to trying to increase the effect of rtms by drugs. And this, of course, this is also one possible development, because we can expect it should be possible in principles to increase these effects pharmacologically.
Thank you for this. Next question is coming from Rodrigo Yarzabal. Thanks for this webinar. The question is, I would like to know, how do the researchers select the place of stimulation on the M1? And if there is a relation between the location of patient's pain report, for example, pain in the hand, and the stimulation,
Yeah. So why M1? So actually, this was, as I said, this was empirical. This was based on the data coming from this Japanese group, showing simultaneously in cat and in man that it was possible to induce analgesic effects by stimulating M1. To be honest, they found it by chance, more or less, because they wanted to stimulate the sensory cortex, and they realized when they analyzed the data that they were closer to the M1 than to the sensory cortex. And then they confirmed that M1 was more effective than S1 to produce analgesia. So this was the first observation. And why these guys did this stimulation? Because they wanted to replace the deep brain stimulation, which were too invasive. But although electrical stimulation of M1 was less invasive than the deep brain, it was still quite invasive, and we cannot use this in many patients. So obviously we wanted less invasive approach. So that's why we chose M1, because we knew that at least it was effective with electrical stimulation. So we wanted to reproduce these effects. But actually, there are very few studies comparing different sites. It has been shown that stimulation of S1 the primary sensory cortex is not effective. rtms of S1 is not effective. For the DLPFC, it's we have negative results, but others have shown positive results, so it's not clear. So probably there are other options. For example, the insula. Many groups are working on the insula, but it is not that easy to stimulate the insula with rtms, because rtms only can stimulate very superficially. So it's more difficult to get to this more profound, more deeply organized cortex. So M1, it seems to be the best so far.
Thank you for this. I'm going to move on to other questions. So it's clear that this is coming from Benjamin Trejo. He's asking, it is clear that neurostimulation is not for all chronic pain. What will be the best patient profile to obtain the best outcome?
I don't know if it is not for all the patients. I would say our data are quite interesting this way. First of all, we included patients, most of the patients that were included in our studies, and we are actually at the moment we are using routinely now rtms in our center. And we are using it not as the first line treatment, but I would say second line. Because when we ask the patients, do you prefer to take a drug for many, many months with all the side effects, or come only once a month to get, and in some patients it's even less than once a month to get stimulated? Most of the patients do prefer the stimulation than taking drugs. So I think, of course, it is not the first line, but it could be probably a second line. And but the problem, and of course, not all the patients are responding, obviously, and in our study, not all the patients were responding. And we are working now, and this was probably the objective of this question. We are now working on the predictive factors, trying to identify the responders, both, of course, mostly on clinical parameters, and try to identify the responders. We already know that actually the response to the first phase, the 5 first days, because as I said, we used daily sessions for 5 days for the first phase. We know that at the end, the response at the end of this phase is very important, and the responders after 5 days are likely to be responding 6 months after, and the non-responders are likely to be non-responders. But we are now analyzing that and trying to prove that, and to try to find other predictive factors.
Thank you. This is actually quite helpful, trying to stratify patients, responders versus non-responders, and trying to see if there are common features. Great. Thank you for that. A question from Jean-Pierre Alibou. What's the future of rtms and pudendal pain?
Jean-Pierre, yes, I know him. Pudendal pain, yes, there are few data suggesting that it could be useful. Pudendal pain is a very complicated condition, and there are data suggesting that could be interesting, but we need more studies to confirm this. But in principle, it could be interesting also in this kind of patients, because many of this pudendal pain have neuropathic components, for example. So and as I said, rtms is not only active on neuropathic pain; it is also active on fibromyalgia and other types of pain. So, because this is not surprising when you look at the potential mechanism of action, there is no reason that it should be only active on neuropathic pain.
Well, thank you very much for this, Didier. I think in the interest of time, we're coming to the top of the hour, and we need to bring this to a close. Thank you very much for this presentation and for answering all of these questions. And I encourage those of you who have questions for Didier, you can post them again, you can send it to him directly. I'm sure he'll be happy to answer them.
Yes, of course. No problem.
Thank you again. Ben, back
Yes.
to you.
Yes, thank you. So I would also like to end by emphasizing, Suleiman, and thanking you, Didier, for your presentation, as well as you, Suleiman, for your excellent moderation. So as a reminder, this webinar will be posted on PERC on IASP's website for viewing. And that viewing is open access. It should be posted within the week. So please keep an eye out for that. On a secondary note, our next Global Year webinar is scheduled for June 23rd. The topic is translating pain knowledge of rare diseases and understudied ethnic groups on sickle cell anemia. And that is by Dr. Keisha Roach. So please keep an eye out for that in the coming weeks. And thank you all again for attending. Thank you.
Thank you.
Bye.
Goodbye.
Goodbye.